This recording is for Chapter 16, Depressive Disorders. Symptoms of depression have been described almost as far back as there is evidence of written documentation. An occasional feeling of sadness is common among healthy people and is a normal response to everyday disappointments in life, but pathological depression occurs when adaptation is ineffective and the symptoms are significant enough to impair functioning. Depression is an alteration in mood that is expressed by feelings of sadness, despair, and pessimism. There is a loss of interest in usual activities, and somatic symptoms may be evident. Changes in appetite, sleep patterns, and cognition are common. Major depressive disorder, or MDD for short, is one of the leading causes of disability in the United States. The lifetime prevalence of depression is about 21%, making it the most prevalent psychiatric disorder. There's an increased incidence of depression among American teens and young adults, especially among adolescent girls. One statistic from 2019 showed that 15.7% of American teens between the ages of 12 and 17 have reported having at least one major depressive episode within the last year, and 11.1% of those had severe impairment. Teens with depression are more likely to use substances, and there's also a correlation between these statistics and increased suicide rates among teens. So this is a major public health issue. The overall lifetime prevalence of depressive disorders is higher in those aged 45 and younger, but it is difficult to pinpoint a single age correlation because there are many factors that influence age-related depressive symptoms. Depression is more common in women than men, and this could be because of several reasons, including that women have a higher concentration of monoamine oxidase, which is a neurotransmitter associated with depression. They're more likely to have thyroid dysfunction and other hormonal changes related to their menstrual cycle, the postpartum period, and then again at menopause. Psychosocial factors contribute to depression in women as well, such as an increased sensitivity to stress, having multiple social roles, and poorer coping mechanisms. Single and divorced people are more likely to have depression than married people or people who are in a long-term relationship. Studies aren't sure why this is, and they don't think that marital status alone is an indicator. Some studies say that age isn't as important of a variable among both married and single people, but marital stress has been associated with an increased risk of depression. So overall, the suggestion is that social stress leads to depression or a lack of social connectedness rather than marital status itself. Seasonal affective disorder are disorders that are more prevalent in the fall and winter. These disorders have a seasonal pattern to them. However, studies have not shown evidence of seasonal patterns for major depressive disorder, but people with seasonal affective disorder, otherwise known as SAD, are more likely to have depression in the winter months. Major depressive disorder is characterized by depressed mood, loss of interest or pleasure in usual activities, and impaired social and occupational functioning that has existed for at least 2 weeks for most of the time during 2 weeks or longer. The patient has no history of mania, and symptoms cannot be attributed to any other medical condition or substance use. Symptoms can be mild, moderate, or severe, depending on whether there is evidence of psychotic, catatonic, or melancholic features. Dysthymia is a persistent depressive disorder of feeling sad or down in the dumps. Dysthymia is milder than major depressive disorder and the client does not have psychotic features. The essential feature is that the person is chronically depressed for most of the day and for more days than not, and for at least 2 years. Early onset is considered to be before the age of 21, and late onset is age 21 or older. Premenstrual dysphoric disorder is a disorder where a female has a markedly depressed mood, excessive anxiety, mood swings, and decreased interest in activities during the week before her menses. It improves shortly after her menstruation begins and then becomes minimal or absent in the weeks after her menses are over. Substance or medication-induced depressive disorder is when the depressed mood is associated with intoxication or withdrawal from substances such as alcohol, amphetamines, cocaine, hallucinogens, opiates, sedatives, hypnotics, or anxiety medications. The symptoms meet all the full criteria for depressive disorder. There are also other medications that can cause mood symptoms, including anesthetics, analgesics, anticonvulsants, some antihypertensive cardiac medications, muscle relaxants, sulfonamides, and steroids. Depressive disorders may also be associated with a different medical condition. It is a direct consequence of that medical condition and causes distress or impairment in social, occupational, or other important areas of functioning, just like major depressive disorder does. The cause of depression is unclear, and no single theory or hypothesis offers a clear-cut explanation for the disease. Evidence continues to show that there are probably multiple causations. There has been a genetic link suggested based on numerous studies, and family studies have shown that major depression is more common among first-degree relatives of people with a disorder than among the general population. Depressive illness may also be related to a deficiency in the neurotransmitters norepinephrine, serotonin, and dopamine, and also acetylcholine at important receptor sites in the brain. And neuroendocrine disturbances may play a role in the pathogenesis or persistence of depressive illness. In clients who are depressed, the normal system of hormonal inhibition fails, resulting in a hypersecretion of cortisol. Thyrotropin releasing factor from the hypothalamus stimulates the release of thyroid-stimulating hormone, TSH, from the anterior pituitary gland. A number of medications, either alone or in combination with other medications, can produce a depressive syndrome as well. Most of these medications have a direct effect on the central nervous system. An individual who's had a stroke, brain tumors, particularly in the temporal lobe, Alzheimer's disease, Parkinson's, Huntington's disease, or MS may also display symptoms of depression. Also, excessive levels of sodium bicarbonate or calcium can produce symptoms of depression, as well as deficits in magnesium, sodium, or potassium. There's also thought to be a role that inflammation plays in leading to depression. There are several different theories that have been hypothesized as to what predisposing factors of depression are, but probably one of the most widely recognized theories is the transactional model of stress and adaptation, which basically recognizes that it's a combination effect of genetic, biochemical, and psychosocial influences that influence someone's susceptibility to depression. Depression, along with dementia, are common psychiatric disorders among the elderly. The aging individual's adaptive coping strategies may be seriously challenged by major stressors that they face, such as financial problems, physical illness, changes in bodily functioning, and an increasing awareness of approaching death. The problem is often intensified by numerous losses that they may experience, such as losing a spouse, friends, children, their home, and their independence. When they experience such a great number of losses, that phenomenon is called bereavement overload. Some symptoms of depression in the elderly are similar to those in younger adults. However, depression is often confused with other illnesses associated with the aging process. Symptoms of depression are often misdiagnosed as neurocognitive disorder, when in fact, the memory loss, confused thinking, or apathy of neurocognitive disorder may be the result of depression. Also, many medical conditions present with the classic signs of depression. Many medications that the elderly take, such as antihypertensives, corticosteroids, and analgesics, can also produce a depressant effect. Depression accompanies many of the illnesses that older people are affected with, such as Parkinson's disease, cancer, arthritis, and the early stages of Alzheimer's disease. Treating depression in these situations can reduce unnecessary suffering and help individuals cope with their medical problems. Then there's postpartum depression. This may last from a few weeks to several months after birth and is associated with the hormone changes that a woman's body goes through after she gives birth. Symptoms can fluctuate from moderate depression to severe depression with psychotic features. About 50% of these episodes actually begin prior to delivery. If a woman has onset of depressive symptoms during pregnancy or before pregnancy, she is at an increased risk for developing postpartum major depressive disorder. Major depression with psychotic features occurs in about 1 to 2 out of every 1,000 postpartum women. In contrast, I wanted to mention baby blues, which are feelings of worry, sadness, and fatigue after having the baby. Baby blues are very normal as those hormone changes happen after delivery and they're trying to re-regulate in her body. These symptoms affect about 80% of mothers and usually subside within a week or two. Symptoms of moderate postpartum depression have been described as depressed mood varying from day to day, with more bad days than good, and experiencing fatigue, irritability, loss of appetite, sleep disturbances, and loss of libido. In addition, the new mother expresses a great deal of caring for her baby and maybe even also for herself. Postpartum depression with psychotic features is characterized by depressed mood, agitation, indecision, lack of concentration, guilt, and an abnormal attitude toward bodily functions. These symptoms can be severe and incapacitating. There's a lack of interest in the baby or even a rejection to have the baby or care for the baby, or a morbid fear that the baby may be harmed in their care, accompanied by delusions and hallucinations. The risk of suicide and infanticide should not be overlooked. There is a 30 to 50% likelihood of postpartum psychosis recurring with subsequent pregnancies. Here are the symptoms for mild depression. These symptoms are like those symptoms that are associated with normal, uncomplicated grieving. Moderate depression includes feeling helpless, powerless, having slowed movements, slumped posture, limited verbalization, difficulty in thinking, problems concentrating, either anorexia or overeating, sleep disturbance by either sleeping too much or too little, and having headaches and other physical symptoms. Dysthymia, which is also called persistent depressive disorder, is an example of moderate depression, and it represents a more problematic disturbance in that it is characterized by symptoms that are lasting at least 2 years. Severe depression includes both major depression and bipolar depression. Severe depression includes feelings of despair, worthlessness, flat affect, psychomotor retardation, lack of communication, possible delusional thinking with delusion of persecution, somatic delusions related to aches and pains, illness, confusion, suicidal thoughts, and a general slowdown of the entire body. Some ways to manage depression include medication management, assertive techniques, stress management, increasing self-esteem, and electroconvulsive therapy, and I'll go into these a little bit more. We also want to make sure that the client and family are aware of support services that are available. So providing them with suicide hotline numbers, letting them know about support groups that they can join, and any legal and financial assistance that may be available. So therapy is an important part of treatment. Individual psychotherapy can be helpful, or it can be done with a group. Family therapy may be appropriate depending on the situation. And then cognitive behavioral therapy can be very helpful at looking at thought distortions and considering how they can maintain their mood and how they can look at things objectively rather than using dysfunctional patterns of thinking. Another treatment is electroconvulsive therapy, or ECT. It's kind of like an outpatient surgery, so the patient needs to be medically cleared for this. They do get medications for this, including a muscle relaxant and an anesthetic, so they do need an artificial airway for a short time during the procedure. There are some risks to this, but usually the biggest thing is a little bit of temporary memory loss and some confusion right after they wake up. Transcranial magnetic stimulation is a procedure that is done by stimulating the nerve cells in the brain using short pulses of magnetic injury to stimulate nerve cells in the cerebral cortex. It's similar to the electrical activity that is seen in ECT, but unlike ECT, it does not cause a seizure. It is non-invasive and is considered generally to be safe. Vagal nerve stimulation involves implanting an electronic device in the skin to stimulate the vagus nerve. We don't really know why this works, but people with chronic recurrent depression have improved when they've had this stimulator. There are still trials going on to determine the effectiveness of vagal nerve stimulation. Deep vein stimulation is where an electrode is implanted with the intent of stimulating brain function. This procedure requires a deep implant and requires a craniotomy. So this procedure is reserved for patients who have severe incapacitating depression or obsessive compulsive disorder. And then light therapy has been shown to be an effective treatment for seasonal affective disorder. There's a light box which patients can use at home that is used for a certain period of time, and it is believed that using the light therapy at home is related to retinal stimulation, which triggers a reduction of melatonin and increases serotonin in the brain. Antidepressant medication is usually the first-line treatment for severe depression and also other types of depressive disorders. There are tricyclics, SSRIs, SNRIs, MAOIs, and some others, but those are the most common. There are safety issues with all of these. Some of these antidepressant medications can be lethal in an overdose. So if you have a depressed patient who's at risk for suicide, they need to be observed closely, and they may be given only a prescription for a short duration, and they'll need to get their prescription filled more frequently. That way they don't have enough medication on hand to where they can overdose. Tricyclics are especially dangerous for that. We want them to take the medications for at least 4 weeks. If there's not a therapeutic response within those 4 weeks, they may need to have their medications changed. They should not discontinue their medication abruptly. Things to report to their doctor are listed here, and if they experience any of those symptoms, they will probably be stopped from taking the antidepressant that they had been prescribed. Some other considerations, people should not drink alcohol when taking antidepressants because they can potentiate the effects of each other. And people who are taking tricyclic antidepressants should not smoke because smoking increases the metabolism of the medication. MAOIs are not prescribed very often because they do have some serious side effects. They also have a very limited diet. So some of the foods that they need to avoid are listed here. It includes things like aged cheese, wine, beer, chocolate, coffee, tea, smoked meats, canned figs, raisins, and others. And not following that diet can cause a hypertensive crisis, which can be a life-threatening side effect. Here are some additional foods that should not be eaten when someone is taking an MAOI. And there are also some over-the-counter medications that can interact with them. So if you look on a lot of over-the-counter medications, you'll see a warning that if you're taking an MAOI, you shouldn't take that medication. Some of these things are like cold medicines and diet pills. Antidepressant prescribing is kind of a trial and error basis. Between 30 to 50% of people don't respond appropriately to the first antidepressant that they're tried on. So there is a possibility of doing genotyping, in which a patient does a saliva sample and sends that in, and then they get a readout of which medications are most likely to work for them depending on their genetics. This is starting to become a lot more popular, and it is a really good tool to be able to prevent having to switch patients from medication to medication.